Welcome to Healthy Focus, the Duke Raleigh Hospital Community Education Series.
Please join me in welcoming Dr. Vinod Krishnan.
Thank you. You can hear me in the back? Yes. Okay. So hopefully today what I could do is make a little bit more sense of the peripheral nervous system for you. You know, in general, I think we can keep this not so formal. If you have any questions that just need clarification on any of the slides, just feel free to shout it out. If it's maybe a little bit more of an in-depth question, then perhaps you can hold it to the end of the conversation. But today we'll be talking about the peripheral nervous system, the anatomy, physiology, and pathology, and I'll explain what that means a little bit later. Starting out with anatomy, this is going to basically answer the question of what is it? What is the peripheral nervous system? Before we even get into this is a slide. I'm going to be using a lot of terms here, general anatomic terms. This is kind of a glossary of those terms. I'll kind of go through these terms with you right now. It might be a good idea to just hold onto that first sheet of paper and put it to the side so you can make sense of everything that comes after. Most of the time that I'm using these terms, it's in reference to the center point of the body. So medial means closer to the center point, lateral means farther away from the center point. Superior or rostral means further up, inferior or caudal means further down. Ventral or anterior both mean in the front, caudal or posterior both mean the back. Proximal generally means closer to the core of the body. Distal generally means farther away from the core of the body. The last three terms, axial, sagittal, and coronal, there's actually a picture here that helps explain what they are. These are relevant when you're looking at imaging of the body. So the axial plane is this transverse plane here. It's a plane that's basically parallel to the ground. So if you're getting something like a CAT scan, it's usually an axial plane. The sagittal plane is a plane that's perpendicular to the ground when you're standing. It's one that's along the axis from front to back. So these are sagittal planes of my body. A coronal plane is that rotated 90 degrees. Again, perpendicular to the ground. These are coronal planes of my body. So the nervous system, generally speaking, is made up of the central nervous system and the peripheral nervous system. The central nervous system is the brain and the spinal cord. The peripheral nervous system is basically everything else in the nervous system, encompassing cranial nerves, nerve roots, peripheral nerves, plexus, rami, etc. And we'll kind of go through these one by one. The peripheral and central nervous system are in continuity at certain points. In the brain, that's called the brain stem, and that's where the cranial nerves emerge. In the spinal cord, the ventral and dorsal nerve roots will emerge. This is the interface of the peripheral and central nervous system in the two areas of the body. So what is the brain stem? It's a vertical stalk that extends inferiorly to the brain. There are two pictures here. On the right side, it's almost like we're looking at someone and they're looking right back at us. This is the anterior part of the brain stem. If you counted it out, there are actually 12 of these cranial nerves sticking out on each side. Some of the cranial nerves are made up of multiple little rootlets. These are the peripheral nervous system part of the head. This is a coronal cut, just like this through the brain stem. You can see the various colors. The red, the green, and the blue are actually the nuclei of those nerves. So the nerves are originating within the brainstem. So sometimes when you actually have problems in the brainstem, it can affect the cranial nerves. Same thing happens in the spinal cord. Here you can see that there are ventral or anterior roots, posterior or dorsal roots exiting the spinal cord. The spinal cord is an extension of the central nervous system. So upstairs we have the brainstem and the cranial nerves. That's the interface of the peripheral and central. Further down, the spinal cord and the anterior horn cell and dorsal root are the same analogs. In general, the cervical region has 8 nerves that are going to come out, 8 roots. The thoracic will have 12, the lumbar will have 5, and the sacral will have 5. So we've already talked about roots. What exactly are they? The ventral root, or the anterior root, originates in this thing here. This is called the anterior horn, and the nucleus of it is called the anterior horn cell. It originates within the spinal cord. It's destined to go to a muscle and provide motor strength at some point. It doesn't do it yet. It won't happen for a while, but ultimately that will provide strength. The dorsal root, actually the cell body lies outside of the spinal cord, so it's a little bit different. I won't go into detail about the relevance of that now, but that does help me diagnostically when I'm trying to figure out what's causing a problem. But likewise, the dorsal root will exit the back of the spinal cord, and then these two will end up coming together. Where they come together is the spinal nerve. Like the dorsal and ventral roots, nothing is happening here functionally. These are the elements that are destined to do things eventually, but nothing has happened yet. So importantly, once you get to the level of the spinal nerve, you're merging both the sensory and the motor fibers. About a centimeter later, it divides into the anterior and posterior rami, and this is when things finally start to happen. The posterior rami immediately turn around and they supply sensation to virtually the entire back and some of the back of the head as well. They supply motor sensation to the paraspinal erector muscles. These are longitudinal muscles that lay parallel to the spine and help maintain the erect body posture. The anterior primary rami, the sensory function, is virtually the entire front of the body, including the entire limbs, front and back, in both the arm and the legs. We'll talk a little bit more about dermatomes in a few slides. Motor-wise, importantly, from C5 to T1, the anterior primary rami will supply the entire motor function of the arm. L1 to S1 will do the entire motor function of the leg. In between, you have also what are called intercostal muscles and abdominal muscles. And generally, you can correspond the number and the level with various parts of the body. We'll again get into that in a little bit. I guess a little bit is right now. So this is a dermatomal slide. So what you see here is basically the body being sectioned off. You'll see a letter, CTLS, corresponding with cervical, thoracic, lumbar, or sacral, and then a number corresponding to the nerve root. As I said before, there are 8 cervical nerve roots. So you see, actually C1 doesn't have a sensory territory. That's why it's not listed. But you see C2 to C8, T1 to T12, L1 to L5, S1 to S5. So you can generally get an idea of what sensory territory a sensory nerve root is destined for based on this type of a designation. Things never work out this nicely in real life. There's a lot of overlapping of the dermatome. So for instance, if someone has a radiculopathy or an abnormality of a nerve root for C6, you could expect it to nicely go down and do this entire part of the arm, but in real life that rarely happens. The territory of abnormality is usually much smaller than that because C6, the slack will be picked up from C5 and C7. So we talked about the nerve roots, the spinal nerve, the rami. Now the next level down, if we're moving distally from the medial part out, is the plexus. In the arm you have something called the brachial plexus. In the leg you have something called the lumbosacral plexus. This is in the arm made up of the anterior primary rami of C5 to T1, which is C5, 6, 7, 8, and T1. This is all the sensory and motor function of the arm. There are lots and lots of nerves that come off of the brachial plexus, and too many to talk about for the purpose of this talk, but the 5 major nerves that go down and innervate the arm, innervate just means supply function to. The 5 major nerves are the median, ulnar, radial, musculocutaneous, and the axillary. This is an artist's depiction of the brachial plexus. Here you can see the anterior primary rami from C5 all the way down to T1. That's what's happening right here, C5 to T1. By convention, for whatever reason, people refer to the most proximal part of the brachial plexus as roots. But technically and anatomically speaking, as we just discussed, these aren't actually the roots. These are the anterior primary rami. At any rate, after the roots come out, they coalesce and form the 3 trunks, superior, middle, and inferior trunks. Then these will divide into anterior and posterior divisions to make cords, and then the cords will ultimately give rise to the terminal nerves of the arm. So we'll start with the median nerve. This is the nerve that basically separates us from the animals. It gives us an opposable thumb. It, in fact, does many of the thumb movements. It also works as a lateral wrist flexor, meaning this is lateral. It'll help flex the wrist. It provides motor function on this side. The ulnar nerve, as it turns out, is a medial wrist flexor. And it also does pronation. Pronation refers to going from palm up to palm down. The ulnar nerve is a muscle, like I said before, that does the medial wrist flexors. It also does deep finger flexors for these 2 fingers. And the word deep comes from the actual name of the muscle that it supplies, called the flexor digitorum profundus. Profundus means deep. But the bottom line is what that does is flex the very end of your digits. It also does the intrinsic, almost all the intrinsic muscles of the hand. So if I take a step back and tell you about a muscle, it has to originate and insert onto a bone. Every muscle does this. That's how we produce movement. When the muscle contracts, it'll make those bones move. That's what a movement is. So intrinsic hand muscle means that the origin and the insertion are within the hand. The ulnar nerve does all of them except for about 4.5, and the rest of those are from the median nerve, and a lot of those are the thumb movements. The radial nerve is the big extensor of the arm. It will extend the elbow, it will extend the wrist, and it will extend the fingers. On this side of the picture is the sensory territory covered by these various nerves. The median nerve, typically on the palmar aspect, is going to do these 3 fingers in the entire palm, and there's a variable contribution to the 4th fingers. Anatomically, when you're numbering the fingers, the thumb is number 1, the pinky is number 5. 1, 2, 3, 4, 5. So it does digits 1, 2, 3, typically half of 4, and you can kind of see that happening in that picture there. And then the ulnar nerve does the other half of 4, and then all of 5. There's a lot of anatomic variation in that 4th digit. If you had to put money on it, you can pretty much guess that the ulnar nerve is going to do your pinky, the median nerve is going to do your 2nd digit, but everything else can be anywhere in between. The thumb is actually split between the median nerve on the front and the radial nerve on the back. As you can see on the back of the hand, the back of the hand in the blue here, the radial nerve is doing a lot of what the median nerve did on the palmar aspect of the hand. The axillary nerve is a nerve that innervates the deltoid muscle. The deltoid is a powerful arm abductor. It's not the only muscle that does that, but one of the more prominent ones. Abduction means elevation and taking it away from the body. The musculocutaneous nerve innervates the bicep, which is the main flexor of the arm at the elbow. In addition to that, we talked about how the median nerve does pronation. The musculocutaneous is a powerful supinator, making you go from palm down to palm up. That's called supination. So we talked about the brachial plexus in the arm. In the leg, the analog is the lumbosacral plexus. That consists of the anterior primary rami from L1 to S1. And just like the brachial plexus does everything in the arm, the lumbosacral plexus does everything in the leg. Likewise, there are some major nerves that come off of the lumbosacral plexus that we'll talk about, and then a whole lot more that we're not going to have a chance to get into today. This is a picture of the lumbosacral plexus, and you can see it's not to be outdone by the complexity of the brachial plexus. It in and of itself is a huge mess of a tangle. Anatomically speaking, it's actually made of 2 parts, the lumbar and the sacral plexus, and there is a kind of a merger in between called the lumbosacral trunk, but we won't get too in-depth into the anatomy of that. That's obviously a lecture in and of itself. So the obturator is a nerve that will innervate your leg to cause hip adduction. That brings your legs together. Adduct means bring it towards the body. The pelvic nerves will help with hip abduction, which is the exact opposite of that. The femoral nerve is the nerve that innervates your quadricep muscle on the top of your thigh. That's a very powerful knee extensor that straightens out your leg. The pelvic nerves, in addition to doing hip abduction, they also help with hip flexion, which is kind of just bending at the waist, and hip extension, which is just bending your leg in the opposite direction. The sciatic nerve will come down through the back, and it'll ultimately innervate all of the hamstring muscles except for one. The hamstrings are the main muscles that cause knee flexion. After it gets to about the level of the knee, I should have included a picture with this, but the sciatic nerve will divide into the peroneal and the tibial nerves. The peroneal nerve, what it basically does is it lifts your foot up, it lets your foot go out, called eversion, and then it'll lift your toes up. The tibial nerve will do the literal opposite. It will push your toes down, it'll push your foot down, and it'll invert your foot. This picture is analogous to the one I showed you earlier of the hand and the sensory territories of the median, ulnar, and radial. Things are a little bit more complicated in the leg. It doesn't have the same nomenclature corresponding to the motor nerve. You have the sural, superficial peroneal, medial plantar, lateral plantar, saphenous, etc. I'll just briefly mention the autonomic nervous system. We're not going to get too into this. This is definitely part of the peripheral nervous system, but it's a very complex part of the nervous system that you can have many, many lectures on. This is generally under involuntary control. So what does that mean? Voluntary control means if I want to, I can flex my arm, I can straighten out my arm. Involuntary control are the things that I cannot control on my own. like my heart beating, like my blood vessels getting bigger, my blood vessels getting smaller, like lacrimation, like my salivary glands. I can't control the way that food moves through my gut. This is all the autonomic nervous system. The two main components are the sympathetic and parasympathetic. Sympathetic nervous system controls what you've probably heard of as a fight or flight mechanism. It kind of upregulates your entire body. You can generically think of the parasympathetic nervous system as doing the opposite, but it's not that black and white at all. The sympathetic portions of the nervous system originate in the thoracic and lumbar areas. The parasympathetic part of the nervous system originates from the cranial and the sacral areas. So I'd like to move on to physiology then. We talked about what it is. Now the question is, how does it work? So the basic functional unit of the nervous system is the neuron. This will basically create and conduct electrical impulses. Believe it or not, these neurons are not in continuity with each other. They're not touching each other at all. In fact, they don't even interact electrically with each other. They interact chemically with each other. They communicate via synapses, which we'll talk about a little bit later. Neurons come in many, many different types of shapes and sizes in every color of the rainbow, but for the purposes of this speech, I'm just going to give you the most generic model of a neuron that we can use, and that's this guy here. He's got a cell body, dendrites, axon, synapse, and I believe that's muscle fiber down there. So the cell body you can think of as kind of the command center of the neuron. The dendrites are basically the parts of the neurons that are receiving information. The axon is the long stalk through which axon impulses will propagate downwards towards the synapse. And the synapse is actually the electrical chemical interface between the neuron and whatever it's trying to talk to. Starting with the cell body, here you can see two cell bodies of two different neurons, and within them you can see kind of a dark purple egg-shaped nucleus. The nucleus is where all the activity is occurring in the cell body. It synthesizes proteins and a lot of the other regulatory mechanisms of the entire neuron. It'll make basically everything that the neuron needs for structure and for function. So if you think about it, the part of the neuron that's closest to the cell body has a huge advantage compared to the part of the neuron that's farther away. And that'll come up later. The dendrites are kind of these branchy structures that come out of the cell body, and as it turns out, dendrite is Greek for tree. They generally receive information. They receive both excitatory and inhibitory information. They will ultimately help determine whether or not a cell depolarizes. Depolarization refers to whether or not a cell activates. Believe it or not, this is a black and white scenario. Either the cell turns on and activates and depolarizes, or it does not. This is called the all or none phenomenon. There is no in between. You either do reach depolarization threshold or you don't reach depolarization threshold. And this is due to the summation of excitatory and inhibitory impulses that come from other neurons and touch the various branches of the dendrites. As I said before, the major function of the axon is to propagate impulses. So generally speaking, let's say that the dendrites have received enough excitatory impulses, they're going to trigger an action potential. That action potential will then start near the cell body and travel down the axon towards the synapse. As it turns out, in a biologic tissue, electricity doesn't travel at the speed of light. It's not like you just flip on a light switch and it's almost there immediately. Because it has to go through biologic tissue, it goes pretty slow. So in order to speed this up, the axons have come up with a novel mechanism called myelination. The myelination occurs differently in the central and peripheral nervous system. In the peripheral nervous system, you have these things called Schwann cells. This is a Schwann cell, that little purple box surrounding the axon there. In the central nervous system, you have a different cell altogether called an oligodendrocyte. In the central nervous system, one oligodendrocyte can myelinate many, many different axons. Completely different in the peripheral nervous system, where one Schwann cell will surround one axon, and it doesn't even surround the entire axon, it just surrounds just a portion of it, and that's critically important because there are gaps in between the Schwann cells. That gap is called a node of Ranvier, and that node of Ranvier is what speeds up the impulses in what would otherwise be slow electrical conduction through this biologic tissue. You can think of it in such a way that the impulses jump from one node to the other to the other. So the major, thickly myelinated, the more myelin you have, the bigger the diameter, the more flow you're going to have of current. So those bigger neurons, the ones that are in our arms, they can conduct at about 50 meters per second, 60 meters per second. which is on the order of like 120, 130 miles per hour. The smaller unmyelinated axons, they conduct probably 10 meters per second, which is going to be like 20 miles per hour. The ones in the central nervous system are even faster than this, and they can get up to like 100 meters per second. So the axon structure consists of neurofilaments and microtubules. The neurofilaments basically give the structural stability to the cell so it doesn't collapse. The microtubules are important in transport. There are two types of transport, an anterograde transport and a retrograde transport. Anterograde means it's made in the cell body and then it transfers down the cell body to the synapse. Retrograde is the literal opposite. It's down near the end of the axon and it transfers back to the cell body. So why would you need retrograde transport? The cell, like most tissues in the body, is constantly being turned over, and you need to get that back to the cell so it can be excreted to the cell body. Anterograde transport is very important because this is how a cell heals itself when it's damaged. Unfortunately, it heals itself with slow anterograde transport, not rapid transport. And slow anterograde transport is just that, very, very slow. It's typically on the range of like a millimeter or two a day. So after about a month, you can expect a nerve that's been damaged to grow just over an inch, which is important because if you're looking at models of nerve injury, nerves don't stay viable for long if they've been transectioned. They'll start to break down. And if they don't get where they need to go and reestablish communication within about 6 months, the nerve is gone and it won't come back. In the central nervous system, it's even worse. Once that nerve is gone, it's gone for good. There is no regeneration, period. So in this case, it's much better for nerves to have a shorter distance of transection between two damaged ends compared to a longer ones. For multiple reasons. Not only this, but if there is a long distance between the two, the little fascicles that grow out and trying to meet each other, they have a lot more territory to cover. They end up going in bizarre directions, and they'll end up forming these big balls called neuromas, and nothing functional will ever get restored. So next we have the synapse. This is the end of the neuron. This is how it communicates with whatever it's trying to talk to, a skin, a muscle, or another nerve. So, like I said before, the electrical depolarization through the neuron doesn't simply just electrically depolarize the next one in line. What happens is neurotransmitters are released. There are lots of different types of neurotransmitters that you could broadly group into excitatory and inhibitory. What happens is when that depolarization comes to the end of the axon, it'll trigger an influx of calcium. These neurotransmitters are already stored in these vesicles, and once they sense calcium, for whatever reason, calcium will make these vesicles join up with the end of the axon, and this process is called exocytosis. The neurotransmitters will be released, and if they make it there, they're going to hit these receptors on whatever the nerve is trying to talk to. Let's just say that it's trying to talk to another nerve. If you get enough of these excitatory neurotransmitters to talk to that nerve, it'll trigger a subsequent depolarization in the next nerve in the chain, and then that nerve will travel its electricity down to its end, it'll release neurotransmitters, and so forth. It's very important to have both excitatory and inhibitory neurotransmitters. You don't want this nervous system to go unchecked. In fact, that's the basis for a lot of pathology, is when you don't have enough excitatory or you don't have enough inhibitory neurotransmitters. Like, for instance, tetanus is basically when you're inhibiting one of the inhibitory neurotransmitters, named glycine, in the spinal cord, so people get locked up. They have an inability to move because their muscles are in a constant state of depolarization. This is a neuromuscular junction. Here you see nerve twigs that are synapsing on muscle fibers. Each nerve twig synapses on only one muscle fiber. Ultimately, this is going to lead to a contraction of muscles. So actin and myosin are the basic filaments in a muscle. You can think of myosin almost like a golf club where the head swivels up and down. So at the top here we have a non-contracted muscle, and at the bottom we have contracted muscle. The actin and myosin haven't changed in their length. They've just changed in the way that they're related to each other. It's almost a situation where they started like this and then they moved together like this. Basically, the way this works is once the nerve depolarizes that's going to the muscle, it will then try to depolarize the muscle. If enough of the neurotransmitter does depolarize the muscle, this will lead to a huge calcium influx in the muscle. Once the calcium hits the actin and myosin, what will happen is that the actin and myosin touch each other like this. Then the myosin will be triggered to cock its head down. That's called the power stroke of the myosin. After that happens, something called ATP will come along that'll make these guys break apart. That ATP is the basic energy cell of the body. Once the ATP is hydrolyzed, that'll recock the head like this. If you continue to have calcium release, it'll sense calcium again and it'll join again. And it'll just keep bringing it down over and over and over. So what happens after death is you lose this ATP. There's no more energy available once you die. So the actin and myosin have already linked, but because the ATP isn't around, there's nothing there to break that link. So the muscles are stuck like that. That's why after death you get this thing called rigor mortis, which is basically an inability to move the limbs around because the muscles are stuck together. As long as there's calcium, those muscle fibers are going to continue to depolarize. So the other function of the nervous system beyond producing motor strength is for sensation. So as it turns out, there are lots of specialized end organs that help with sensation. To start out with, we have Merkel cells. These are slow adapting but constantly firing. So these are important, like in your hand, where you want to be very aware of what's in your fingertips. There's a high density of these in your fingertips. They're very good at feeling the edges of objects in particular. That's why the fingers are so discriminatory when you're looking for edges. Probably the opposite of that are these things called the Meissner corpuscles. These would have probably a higher density in your back. These are rapidly adapting and they're intermittent firing. So they notice when there's a change in something, but they won't notice a constant type of stimulus. So in your hand, I'm always aware that I'm touching this marker, but on my back, I'm not aware that I'm wearing a shirt. I mean, I know if there's a change in the way the shirt is in relation to my back, but I don't need to know the function of my shirt continuously throughout the day. It's a waste of resources. So there's a higher density of those on the back. There are these things called Ruffini endings that particularly look for shearing stress or drag across the skin. Pacini corpuscles are very sensitive to changes in pressure and vibration. Just like the Meissner's corpuscles, these are rapidly adapting and intermittently firing, so they're not constantly aware of this, but just intermittently. And then you have these free nerve endings. They're not even specialized end organs. It's literally a bunch of tiny nerves that come out into the skin of your body, and they sense basically pain and temperature. Those are called the small fibers. This is a little bit off topic, but it's interesting, so I thought I would add it. This is more of a central nervous system process, but this is what's called the homunculus. So on the left side, you have the somatosensory cortex, which is in the parietal lobe. Think of sensory function. On the right side, you have the motor cortex, which is in the frontal lobe, which is your motor function. So what you're seeing here is a pictorial representation of what's important to the brain. So on the right side, you can see how much brain tissue is devoted to the sensory function of like your tongue, your lips, your face, your hand. But you can see there's not a whole lot to like your knee and your heel. And there's generally a correlate to your motor function as well. It's very important as humans that we have great manual dexterity in our fingers. We have very, very good control over our extraocular eye movements and our facial apparatus. But it's not so important that we have fine control over our quadriceps. That's just basically a big, coarse muscle. We don't need fine movements of it. This is another artist's depiction of the motor and sensory homunculus. Basically, what you see here is a body part drawn in proportion to its representation on the cortex of the brain. On the left side, you see the sensory one. On the right side, you see the motor one. So you can see the hands are huge. The face is really big. The lips are big on the sensory one. And on the motor one, the hands are even bigger. And the eyes are really big on this guy, too, because that's what our brains think are important. So getting back on topic here, we've now talked about the various nerves in the body. We've talked about the smallest unit, the neurons. But what's the relation between the two? How do they fit together? So as it turns out, the axons are surrounded by Schwann cells, like we talked about. Surrounding each axon and Schwann cell is endoneurium. Surrounding groups of endoneurial cells is this green connective tissue called perineurium. It's not green in the body, it's green in the picture. So this creates what's called a fascicle. Grouping the fascicles together is the epineurium. And that's what you see when you're actually looking at a nerve, is the epineurium. That's kind of the way that the axons and the nerves are regulated in our body. So if you have a problem in a nerve, sometimes it doesn't affect the entire nerve. It can just affect one of the fascicles. That fascicle can be primarily motor, providing strength. It could be primarily sensory, providing sensation. So because of which fascicle is affected, you can have very different symptoms, even within the same nerve. So finally, what I'd like to talk about is pathology, which basically answers the question, what can go wrong with it? So just briefly, we have cranial neuropathies. This is, like I said, the extension up in the head of the peripheral nervous system. It can be liable to problems with brainstem masses, what's called demyelination, meningitis. Basically, meningitis and all non-compressive causes of cranial neuropathies and radiculopathies that we're going to talk about in a second are due to a process which diffusely affects the cerebrospinal fluid, which is the fluid that these cells bathe in when they're exiting the brainstem, when they're exiting the spinal cord, before they make their way out into the rest of the body. You could have an inflammatory problem there, an infectious one, a cancerous problem there, and your MRI and imaging can look completely normal. On the other hand, you could have a big tumor sitting there causing a compressive problem, or you can have a big solid ball of infection called an abscess. As it turns out, the special case is diabetes, which can cause what's called an infarction of a nerve. Infarction is basically the death of a nerve. So that can pick off various cranial nerves, and it can do the same thing down in your systemic roots. So I'll start by talking about radiculopathies. Radiculopathy, anytime you see the word opathy, it just means pathology of, and as we said before, pathology just refers to something wrong with something. So radiculopathy means that something is wrong with the nerve root. Compressive radiculopathy is what you typically hear about when someone says they have a pinched nerve. If I had to broadly group these into two types of degenerative changes, I would group those into disorders of the disc and spondylosis. Disc herniation, I'll show you in the next slide, there's an intervertebral disc, which is like a gelatinous material that can herniate into places it's not supposed to be and press on nerve roots. Spondylosis is basically an arthritis of the spine. Just like you can have arthritis of the joint of your finger, you can have arthritis of the joints of your spine, and that can cause problems not only with local pain, but it can irritate the surrounding structures. If you know anyone with arthritis, sometimes you can tell their joints are pretty enlarged. In the spine, you're dealing with very small areas, so anytime you have an enlarged structure, it's giving less room to other structures like spinal roots. This is a sagittal view of the spine. It's like you're looking at me like this. Sagittal view is like this. Whoops, sorry. This is kind of a blown up view over here of what we're looking at right here. So you can see the vertebral bodies, and in between them is that kind of Oreo filling. That's the intervertebral disc. This is called the neuroforamina right there, that hole. That's a very important hole because that's the hole that the spinal nerve roots have to exit out of. So you can see there, if that disc is protruding backwards, what was previously a big hole becomes a small hole. Anytime a big hole becomes a small hole, that's a problem for the nervous elements in that area. Although you can't really see it well here, if I showed you an axial cut, which is the next one to show to you now, an axial cut shows that we talked about the hole on the side. This is the hole right behind the vertebral disc. If that gets smaller, it's going to irritate the contents in the back. This is the facet joint right here. This is the major joint of the spine. So just like you can have a joint problem with your finger, you can have a joint problem there, and that can lead to spondylosis, and that can narrow down the hole as well. If that joint becomes enlarged, you're not going to have as much room in the back. If this disc is protruding and you have spondylosis, you may have lost that entire part of your hole, and that's a problem for the nerve roots that need to come out. So this right here is a picture of a herniated disc. So maybe the first thing you can notice is, contrary to probably what you thought, the disc is not one homogeneous structure, it's actually two. You have this ring of fibrous tissue called the annulus fibrosus, and in the middle you have this thing here called the nucleus pulposus. So what typically happens with a herniated disc is you break down through degenerative changes this ring, and that nucleus pulposus will stick out. And as you can see here is depicted by the red, it's irritating this nerve root that's trying to make its way outside of the spine. Going back to the dermatomal chart here, for instance, if that just happened to be the level at, so anytime you hear someone referring to the spine, you'll hear them say something like C4, C5, or L5, S1. What they're talking about is the inner space between it. So that would be L5, that would be S1. This is the L5, S1 neuroforamina. That's what they're talking about, is the space between these two. That would be the L5, S1 intervertebral disc. So if there's a herniated disc, you can't just say a herniated disc at L5. Is it above L5, below L5? If you say L5, S1, then you know it's between the L5 and S1 vertebrae. So going back to this, if I see a herniated disc somewhere and it's compressing a nerve root, I can generally get an idea of what kind of symptoms are going to occur from a sensory perspective. This has nothing to do with the motor function, just the sensory function. For instance, if it's in the neck at C5, C6, then it's going to affect the C6 nerve root. by convention. So C6, I don't even think this is very anatomically correct in this picture, but C6 is typically this portion right down here near the thumb. So a C6 radiculopathy would many times present with someone coming in having problems with pain, numbness, tingling in their thumb. If it was affecting the motor root, then the C6 motor nerve roots would be things like the pronators, the dyspronation, your biceps, your deltoid, and some of the flexors. So that's how I can kind of figure out what kind of symptoms someone is having based on their MRI. But it's never always that easy. Sometimes people will have ridiculously terrible spines on an MRI with an almost complete absence of symptoms. And the corollary is very true as well. Sometimes you'll do an MRI of someone's spine and it looks stone cold normal, and they have 10 out of 10 severe pain all day and every day. There's a very poor correlation between back pain and the imaging findings on the spine. So we talked about compressive radiculopathies. The next thing I want to talk about is neoplastic radiculopathies, not because they're all that common, but just because I saw a patient with it and I have his films here, so I thought I'd show them to you. So there are two major types of neoplastic radiculopathies, compressive and non-compressive. Compressive means that you have a tumor sitting down there somewhere irritating the spinal nerve roots. Non-compressive means that you have a diffuse cancerous spread throughout the cerebrospinal fluid, irritating all the nerve roots as they're exiting the spinal cord and your cranial nerves. In fact, that process is called lymphomatous or carcinomatous meningitis. That is an extremely malignant cancer with death usually within a few months. So this is, I think he was in his mid-30s. He came to see me. His only symptom was that he was having numbness on the anterior aspect of his right thigh when he would sit down. That in and of itself is not helpful to me at all as far as the description of symptoms. I did his examination. It was completely normal. I did some additional testing. It was completely normal. So I decided to do an MRI of his spine. This is a sagittal view of the spine, like this. This is the lumbosacral area. You can usually figure out where you're looking at by this bend right here. This is S1, that's L5. So L5, L4, L3, L2. So that's right behind L2. Believe it or not, that's actually how I can figure out what level we're at. But you see this guy here, this little thing does not belong. It looks very different. And what happened is I referred him to a neurosurgeon, and this is actually an intraoperative ultrasound that was done of his back. So he's laying prone, which means face down. The bones have been removed from his spine, and the surgeon has taken an ultrasound probe and placed it right on the top of the fecal sac, which is a sac that contains the nerve roots. And you can see there's clearly a mass here that's displacing the fibers here. These should otherwise be kind of longitudinal fibers, but they're really being irritated by that mass. Although I didn't mention it, one of his other symptoms was having bowel incontinence. He didn't even mention it at first because it was such a gradual process. He didn't think twice about it. But if I told you this symptom, it would probably, in your minds, be a red flag. He went from going and having normal bowel movements like once a day to every day on his way to work stopping at the same fast food restaurant to have a bowel movement. Every day he would do that. On his way to work, he would stop there. So this mass was removed, and his sensory function got completely normalized almost immediately thereafter, and his bowel function is slowly returning to normal. So he's doing very, very well. So another type of non-compressive radiculopathy would be an infectious one. Lyme disease is a very common cause of non-compressive radiculopathy, as is tuberculosis, HIV, and if you actually have an epidural mass, that's basically a big collection of purulent or pussy material from an infection. In general, infectious radiculopathies are not that common. What I probably see more commonly out of those four I listed there, not that that's an extensive list by any means, would be a compressive epidural mass. Every once in a while, maybe like once every 6 months, I'll see someone come in, and they typically present not so much with radicular symptoms, meaning shooting pain or anything like that, but more of a spinal cord problem. These people will go from walking and talking one day, literally over the course of several hours, to losing sensation, bladder function, bowel function, and complete paralysis of their legs, just from a compressive epidural mass. Those things can be pretty tricky, so it's very important to diagnose them quickly. Other non-compressive radiculopathies are listed below. For the purposes of this talk, I'm not going to really get into those. If anyone has any pressing questions about those, please feel free to ask me about them a little bit later. Moving on, though, we'll move to mononeuropathies. So we've talked about the radiculopathies. Now we'll talk about the mononeuropathies. So in the arm, we already talked about some of the major nerves, and as it turns out, some of those major nerves have pretty classic syndromes associated with them, like you were asking about the carpal tunnel, and we'll go a little bit in depth about that in a moment. So you have a median nerve at the wrist, which is called carpal tunnel, ulnar at the elbow, which is generally called cubital tunnel syndrome, although that's not always technically correct. You have something called the perineal nerve at the fibular head, radial at the spiral groove. I'll talk about that now because I'm not going to go in depth about it. Basically, the spiral groove is a part of your humerus, which is the main bone. It's the only bone in your upper arm. The radial nerve lies very close to the bone in this area, so if you fracture your humerus, you can actually cause a radial neuropathy. The other lesion that you classically get with a radial neuropathy, I may have seen this maybe a handful of times, is something called Saturday night palsy. This basically refers to the guy that goes out, gets drunk on Saturday night, comes home, and passes out on a chair with his arm kind of draped over the rigid part of the chair. That rigid part will compress his radial nerve against the humeral head, causing a radial neuropathy. So he'll wake up with a wrist drop or finger extension drop or a weakness of his arm extension. Tarsal tunnel syndrome is a tibial neuropathy at the ankle. It's kind of similar to a median neuropathy at the wrist in the sense that it's also being caused by a compressive tissue fascial layer. I'm not going to get too into that. It's probably out of those the least common one that I see. Below this, the non-compressive ones, there are lots of things that don't have to be associated with the mechanical compression of the nerve that can pick off various nerves. Lyme disease, once again, leprosy. There are some pretty exotic things like multifocal motor neuropathy, ischemia, which is just a generic term for any process that limits blood flow to a nerve, and then vasculitis or mononeuritis multiplex, which I'll talk about in a moment. So carpal tunnel syndrome. We've already talked about the median nerve and what it does. It technically supplies sensation to D1, 2, 3, and half of digit 4. So people will complain of numbness, tingling, and pain in that distribution. It supplies motor function to the thumb, so you would expect someone to have weakness of their thumb. By far, people will get sensory symptoms far before they get motor symptoms. As it turns out, for whatever reason, this is not how it usually works in real life. It's very rare that someone will come into my clinic complaining of this classic textbook description of carpal tunnel syndrome. More commonly, what people say is that they wake up in the middle of the night, their whole hand is numb, and they have to shake it off. Sometimes people will have numbness, tingling, or pain, not just in their fingers, not just in their hand, but it can go into the forearms, it can make it up to their shoulder. And I saw a guy about 3 months ago who actually had headaches from carpal tunnel syndrome. The only reason I would ever even think that it was from the carpal tunnel is because the headaches got better with the surgery for carpal tunnel. And I guess I should also mention that a lot of times carpal tunnel syndrome is completely asymptomatic. This is typically seen in more of the elderly individual who slowly, gradually over decades has wasting away of the muscles and slow sensory dysfunction to the point where it's not even registered on a conscious basis. Cubital tunnel syndrome, I should say ulnar neuropathy at the elbow. There's a type of ulnar neuropathy known as cubital tunnel syndrome. For the purpose of this talk, we'll just call ulnar neuropathy at the elbow cubital tunnel syndrome. So basically what's going on here is that the ulnar nerve is very superficial at the area between what's called the olecranon and medial epicondyle. So if you reach down and touch your elbow, that's the olecranon. That's what this thing is right here. That's the most distal expansion of, the proximal expansion of what's called the ulna, which is one of the bones of the forearm. If you slide your finger over, you'll feel this little bony protuberance that most of you know of as kind of a funny bone. When you hit that thing, it feels really weird and your hand feels weird. What you're doing is you're injuring your ulnar nerve. The reason is it's so superficial there. What happens is when you flex your arm past 90 degrees, these two areas are splitting apart. These being split apart pulls this fascial layer down on top of the ulnar nerve, and the ulnar nerve does not like that. The other thing it doesn't like is pressure on the medial aspect of your hand. So the double whammy a lot of my patients do is when they're going to sleep at nighttime, they sleep kind of like this on their arm, so their arm is really flexed and they're getting pressure to the inner aspect of their arm. And a lot of times what I'll tell people to do is do some type of a brace to their arm or even tie a towel around it or anything to keep them mandatorily in that extended position. Because most people after sleeping like that for decades, you can't change that voluntarily overnight. The pattern of weakness is pretty variable. you'd think that any muscle innervated by the ulnar nerve beyond this point would be affected. That is not at all what happens in reality. Sometimes people will have just weakness of their intrinsic hand muscles. Sometimes when it's severe, they'll have weakness of their deep finger flexors and the wrist flexors as well. Probably the most consistent thing I see with ulnar neuropathy is people coming in complaining of numbness and tingling in these two fingers and the medial part of their hand. Perineal at the fibular head is not dissimilar to an ulnar neuropathy, not even close to as common. But basically what you have here is a nerve called the perineal nerve wrapping around the fibular head. This part that it wraps around is very superficial and liable to problems. So the classic conditions that can cause this is crossing your legs, just like that. So that's the big one, is crossing your legs. I'll literally tell people not to cross their legs, not in the man style, but in the woman style. That's the one that does it. Also doing things like squatting for extended periods of time. I've seen people that like to work in their garden or down squatting that develop perineal neuropathies. So as we talked about before, the perineal nerve basically lifts your foot up and it everts your foot. So the problem here, motor-wise, is a foot drop. So you have someone, believe it or not, when you're walking, you're automatically dorsiflexing your foot. You're picking it up during the stride phase of walking. If you don't pick your foot up, you're going to trip over it. So they don't even realize they're doing this, but people with perineal neuropathies frequently have what's called a steppage gait, where instead of just bringing their foot forward and tripping on it, they bring their whole leg up and it kind of flops down like that. That's called a steppage gait. The sensory abnormalities in the lateral aspect of the foreleg and the dorsal part of the foot, just the outside of the foreleg and the top of the foot. And that's actually pretty common for people that have perineal neuropathies. The presentation of these is much less variable than carpal tunnel syndrome and for ulnar neuropathies. And this usually presents, unlike the other two, primarily with motor dysfunction in the foot drop. Mononeuropathy multiplex is a condition in which you basically pick off various nerves of various parts of the body. So someone could come in with right median nerve problem and a left perineal nerve problem, or any combination of anything that we've talked about. The two major conditions that cause these are vasculitis and diabetes. Vasculitis is a condition in which you have inflammation of the blood vessels. What does that have to do with the nerves? Just like every other tissue in the entire body, the nerves need blood vessels too. They need nutrients and they need something to take away their excrement. So when you lose that blood vessel going to a nerve, you lose the nerve. This typically has somewhat of a more poor prognosis. These are difficult to treat. Polyneuropathy is what you probably know of as neuropathy. When someone says they have neuropathy, this is what they're referring to. The technical term is a generalized length-dependent polyneuropathy. So going back to what we talked about before, the nuclei of those cells, of the nerves, lie within the spinal cord. So if you look at a nerve, the cell body is right in the front, or right in the center. So the nerve is pretty long. It starts, in the leg especially, it starts somewhere in your spine. It goes all the way down to the tips of your toe, all the way down to the tips of my fingers. So the part of the nerve that's furthest away is going to have a lot of trouble getting nutrients compared to the part of the nerve that's right next to the cell body. I mean, it's the first guy in line to get what it needs. So if you have a process going on that's diffusely challenging the nerves from a metabolic perspective, the first thing to go is going to be the distal part of the nerve, or the farthest away part of the nerve. And that's especially true for the longer nerves. The longest nerve in your body is from your spine to the tip of your toe. So the way that this typically presents is with symmetric numbness, tingling in your fingers, in your toes, that slowly kind of creeps up your leg as that process goes unchecked. As the metabolic requirements outweigh, or the demands outweigh what is actually being given by the cell body, that process that starts down in the toes will very gradually move up the leg. Once it reaches a critical length in the leg, it will approximate the length of the nerve in the arm. When it gets to that point, you're going to start to get the symptoms in your fingertips. There are lots of different things that cause the polyneuropathy, and that's probably more important than the actual diagnosis of polyneuropathy, because that's what dictates what kind of symptoms you're going to have, and it dictates the rate of progression. Let me actually come back to that slide. So going back to the symptoms, common symptoms are numbness, pain, oftentimes described as a burning sensation, reduced proprioception. Proprioception is basically your ability to sense where your body is in space. if you can't tell where you are, if you can't feel your feet, it's very difficult to walk around. So people with the neuropathy frequently say that they feel dizzy or feel off balance. That's their way of verbally describing their inability to feel where they're walking. The other thing they'll often do is look down while they're walking. They're very conscious of where their feet are all the time. In the late stages, you typically get weakness, but almost always early on, the first thing to go is sensory dysfunction, either losing it to get numbness or gaining a sensory problem like pain. Autonomic dysfunction can be seen in a variety of polyneuropathies, especially the ones that do small fiber dysfunction. I told you before, the small fibers do pain and temperature. As it turns out, the autonomic nervous system is also made up of these small fibers. So very frequently, these people that come in with predominant small fiber problems like pain and temperature will also have autonomic symptoms like dizziness going from a sitting to standing position called orthostatic intolerance, erectile dysfunction, early satiety, meaning when you eat something you feel full really quickly, problems with urination, sweating, etc. So on examination, when I'm looking at someone with neuropathy, it basically reflects everything up here, all the symptoms. They'll have reduced light touch, pin prick, vibration, proprioception further away, and it gets better as I move up their legs or arms. They usually have this thing called a positive Romberg sign if their numbness is bad enough. So Romberg, basically what that is you have them put their feet together and close their eyes. If you eliminate your eyes as a contributing factor to maintaining balance, you're primarily referring on maybe about 3 different systems in your body, one of which is proprioception. So people that have severe numbness and reduced proprioception will have a very big difficulty standing with their feet together, even with their eyes open sometimes. The other way I'll test that is I'll have someone close their eyes, I'll take their toe and I'll lift it up or down and ask them which way it's moving. If they can't tell at that point, I'll lift their entire foot up or down and ask which way it's moving. Most people will be able to at least tell that. In the late stages, you'll have someone that has distal weakness, and you'll commonly see reduced reflexes as well, which can be a consequence of either sensory or motor dysfunction. Like I said before, it's not so important that you're diagnosed with a neuropathy. The question is what caused it, and I did skip a slide. Let's go back to that real quick. By far, beyond the shadow of a doubt, nothing is even close to second. Diabetes and impaired glucose tolerance are the most common cause of a generalized length-dependent polyneuropathy. Diabetes everyone knows about. Impaired glucose tolerance is a little bit more nebulous. Your control of diabetes is directly proportional to the amount of damage you're going to have with your neuropathy. Unchecked diabetes will cause progression in your neuropathy. It will get worse. Unfortunately, the corollary is not true. Once damage has occurred from diabetes and you improve it, it doesn't always get better. In fact, in my experience, it usually doesn't get better, but at least it prevents progression. So impaired glucose tolerance is probably the most common thing I diagnose in patients that come to see me with idiopathic neuropathy. Idiopathic is the medical term for saying we don't know what causes it. Impaired glucose tolerance you can consider like a borderline diabetic state. There are good tests for diabetes and great tests for diabetes. There's something called the hemoglobin A1C, which is like a 3-month estimate of your blood sugar control, which is actually very helpful. But the problem is it's not usually sensitive enough to pick up impaired glucose tolerance. So when someone comes to me saying, yeah, my doctor ruled out diabetes, it's not a problem, and they have a neuropathy, 10 out of 10 times I'm doing an impaired glucose tolerance test. That's basically a test in which you fast overnight, you come into the lab and you drink a very gross tasting sugary solution thing, and then they check your blood sugar with that sugar challenge 1 hour later and 2 hours later. They test your body's ability to handle the sugar. They have certain ranges for what's considered normal, and if you're outside of the range, you have impaired glucose tolerance. And you can have the exact same manifestations with impaired glucose tolerance than you can with diabetes. It's been proven time and time again. A lot of times, primary care physicians are pretty resistant to that concept for whatever reason. As it turns out, you don't really need to go on the same medicines for IGT as you do for diabetes. A lot of times I tell people to start out with weight loss or nutritional changes, things like that. But for the most part, I don't get too involved in the treatment of it. There are people much more qualified than myself to manage those conditions. Other very common causes of neuropathies include vitamin imbalances, paraproteinemia, which is almost like a cancerous or precancerous state of the blood cells, infectious causes. In fact, leprosy is the #1 cause of neuropathy on this entire planet, especially in developing nations. Medication side effects, that's a pretty important one for a couple reasons. Chemotherapy can oftentimes cause nerve damage. In fact, chemotherapeutic-induced peripheral neuropathy is often the rate-limiting step in the administration of the chemo. People need to come off of the chemotherapy sometimes because they develop such painful neuropathies. In my experience, those can be very difficult neuropathies to treat. These are very important vitamins to know about: B12, B1, and B6. B6 I mentioned in 2 places for a reason. B12, right off the bat, I check in everyone with neuropathy. Thiamine, which is B1, I sometimes check. That's usually more of a problem in alcoholics. Those are very easy to replete orally for the most part. Sometimes you need to give injections for B12. I found in my own personal experience that 95% of the time oral supplementation with B12 and B1 is adequate. B6 is an important vitamin. It is the only vitamin, the other name for B6 is pyridoxine. It is the only vitamin that can cause a neuropathy both in toxicity and in deficiency. Unlike B12 and thiamine, there is no problem with having too much thiamine. There is no problem with having too much B12 on board. There is certainly a problem with having too much B6 on board. In fact, I've seen a lot of strange things happen from B6 toxicity. People coming in complaining of tingling here, numbness there, a little bit of this, a little bit of that, simply because they're taking some type of a supplement they're getting from GNC or some other place. Not even a B6 supplement, but like a B complex vitamin or a mega men supplement or something like that. It's okay to take like 1 or 2 milligrams, which is probably what you're getting in your typical multivitamin. But if you go out and actually try to get on B6 or take one of these B complexes, you do not want to be taking 50 milligrams or 100 milligrams unless you have been diagnosed to be deficient. Human studies have shown that up to 200 milligrams of supplementation is safe in a human. If someone is deficient in B6, I usually give 50 or 100. Like I said, most of the time people are not deficient, but they will be toxic when I check the B6 level in their blood. And the treatment, simply without doing anything else, is to discontinue supplementation, and there's a miraculous recovery. People do quite well with discontinuation. It's a water-soluble supplement, meaning that it comes in quickly and it leaves your body quickly. A, D, E, and K are the fat-soluble ones. When you take those, they stick around for a while. As I said before, it's not important to know that you have a polyneuropathy. It's important to figure out what is causing it and then target what's causing it. As it turns out, though, about 2/3 of the time I can figure it out, and about 1/3 of the time I cannot figure it out. There are thousands of blood tests out there that I can run on every individual, including some of the more common things like diabetic testing and B12, or the really esoteric genetic tests that I have to send over to the Mayo Clinic. There are cases where I will send those genetic tests in people that have a strong family history and people that have significant disability from their neuropathy, but 95% of the time I'm just going to do the basic testing. So the symptomatic therapy, if someone is coming in complaining of pain, comes down to using one of a variety of pain medicines. My top 2 medicines are Neurontin or gabapentin and tricyclic antidepressants, which is a class of medicines like Elavil or nortriptyline Pamelor. If those don't work, I'll usually move on to carbamazepine, Lyrica, or Cymbalta. The first 3, the Neurontin, TCAs, and carbamazepine are generics. That's another reason I like them. Not only because they're generics, because they work really well. Lyrica and Cymbalta are not generics, they're brand name. In my experience, I haven't had quite as much luck with them, but there are certainly people that do very well on Lyrica. I've had very limited, there's maybe only a couple patients I've seen that have had significant improvement in their pain on Cymbalta. Physical therapy is critical for people with neuropathy that have gait instability or weakness. You want to make sure that people don't fall. That is the worst thing that can happen. Falls are preventable. You do what you can to prevent it. Physical therapy could mean using ambulation assist devices like a cane, a walker, or a rollator, which is one of my more preferred means of ambulation assist. You get wheels, you get handbrakes, and you get a seat. It's got everything you need. This thing here is called an AFO, or an ankle foot orthotic. So a lot of times what you have in people that have weakness of their foot, weakness from a neuropathy, is a foot drop. So as we talked about before, it's tough to get around with a foot drop. You need to make a lot of compensations. One little mistake and you trip and fall over your foot. An ankle foot orthotic will change a position like this to a position like this. It automatically compensates for your inability to dorsiflex your foot. So this can be very helpful, fits right into your shoe. It does provide some mobility of your foot as well. Okay, we'll keep moving along. I guess we are a little bit over time here, and we can do some more questions at the end. Thanks for keeping me back on track. Moving on, motor neuron diseases. There's an upper motor neuron and a lower motor neuron. Upper motor neuron is from your brain to the spinal cord. Lower motor neuron is from your spinal cord down to whatever muscle it's going to ultimately innervate. You can have conditions that affect the upper motor neuron, conditions that affect the lower motor neuron, or conditions that do both. Generally, there are not any cures for motor neuron diseases. These are exclusively motor. There is no sensory symptom associated with these, with one exception. Just think of them as exclusively motor, causing problems with weakness. If it happens in your skeletal muscles, it'll cause weakness in the arms and legs, weakness in your swallowing apparatus, dysphagia, weakness in your speech apparatus, dysarthria, weakness in your respiratory muscles, dyspnea. It can cause trouble with gait stability, not only because of weakness from a lower motor neuron problem, but upper motor neuron problems can cause something called spasticity, making it very difficult to walk. Shortness of breath we talked about. The signs on examination are the analogs to everything there. Oh, just to briefly describe what these are, atrophy is like a wasting of the muscles, or shrinkage of the muscles. Fasciculation is basically, you look down, you'll see a little indentation. Everyone in this room has probably had a fasciculation. Eyelid fasciculations are ubiquitous. Everybody gets them. It's that same phenomenon somewhere else in your body. Motor neuron diseases are typically progressive in nature, sometimes fatal. The prototypical fatal motor neuron disease is amyotrophic lateral sclerosis, or ALS, otherwise known as Lou Gehrig's. This is a combination of both upper and lower motor neuron disease, uniformly fatal across the board. Life expectancy is typically along the lines of a few years, although rarely people can get up to a decade, and I've seen one patient go 20 years. There's a medicine you can take for it, but it's nothing too substantial. It basically prolongs the amount of time it takes for you to require a ventilatory assist device. Primary lateral sclerosis and progressive muscular atrophy are the upper and lower motor neuron components of ALS. If you just have upper motor neuron, it may be PLS. If you just have lower motor neuron, it may be PMA, and those can turn into ALS. These are some other motor neuron diseases. Kennedy's disease, for whatever reason, you can sometimes see some sensory abnormalities, but the rest of these are predominantly motor. Moving on, myopathies. Like motor neuron diseases, these are purely motor in nature. This is a disorder of the muscle. The main types of muscle are skeletal, smooth, and cardiac. Cardiac is the easiest. It's the muscle of the heart. A heart attack is a myocardial infarction, an MI. That's basically when that heart muscle dies. The heart is pumping blood, so if you lose that muscle, you've got a problem. Skeletal muscle is the voluntary muscle of the body. It's when I want to flex my arm, I can flex my arm. That's my skeletal muscle. Smooth muscle is a muscle that lines your blood vessels, it lines your gut. It keeps stuff moving. You have no voluntary control over it. That's controlled by the autonomic nervous system. For whatever reason, in myopathies, you typically have proximal weakness. Neuropathies are typically distal weakness, weakness in your hands, weakness in your feet. Myopathy is more of shoulder girdle, pelvic girdle weakness. You can have facial weakness, weakness of your eye movements, and like motor neuron disease, you can have diaphragmatic weakness, which causes shortness of breath. In the interest of time, I'm not going to go through all this. The big one I'll talk about is drug-induced myopathy. The class of medicine is known as statins. Many people are on statins for things like heart disease and strokes. You've heard of them as Lipitor, Zocor, Crestor, things like that. Certain ones have a higher probability of causing statin-induced myopathy than others. There are many models of statin-induced myotoxicity. It can damage your mitochondria. It can actually induce an inflammatory myopathy. It can cause direct necrosis, just to name a few. The treatment isn't even necessarily withdrawal of the statin if the symptoms aren't too bad, but usually coenzyme Q10 supplementation can be very helpful in my experience for people that have statin-induced myopathies. If you need to be on a statin for other medical reasons, you may want to try one of these guys down here. They have a lower probability. And before you even want to try that, you might want to try niacin. Back in the day, before the drug companies came up with the statins, niacin was the main medicine that people used for cholesterol control. The problem is it has a side effect of facial flushing, and people don't tolerate it very well. Sometimes you need to pre-treat with aspirin or take it at nighttime with a meal. Neuromuscular junction disorders affects the synapse. That's the electrochemical interface between a nerve and a muscle in particular. You're somehow screwing up that synapse and the neurotransmitters getting from where it needs to go to where it needs to go. Again, this is exclusively motor in nature. It oftentimes causes fluctuating weakness. Weakness that's worse towards the end of the day. Weakness that is associated with fatigue. Very commonly, people will have weakness of their eye muscles, especially with myasthenia gravis. Which is something I'll talk about in a moment. You may or may not have autonomic symptoms, and this can affect your breathing apparatus like motor neuron diseases and myopathies. So again, just to remind you here, this is the synapse, these are the neurotransmitters. Myasthenia gravis is a postsynaptic problem after the synapse. where you have blockage of the neurotransmitters. Lambert-Eaton myasthenic syndrome is a presynaptic problem where you have an antibody to the calcium-mediated exocytosis of those neurotransmitters. Remember, you need calcium to get those neurotransmitters out. This antibody blocks it. You don't get the neurotransmitters out. Botulism is another presynaptic process where you don't even get to form these vesicles due to a toxin. Plexopathies, I'm going way over in time here. I'll just go real briefly through this. You can have penetrating injuries, inflammatory injuries, shoulder dislocation. By far the most common thing I see causing brachial plexopathy is something called idiopathic plexopathy, which is also known as Parsonage-Turner neuralgic amyotrophy and brachial neuritis. This is an idiopathic, meaning we don't know what's causing it. Brachial plexopathy, you typically get very severe shoulder pain, and then after a day or two, the shoulder pain goes away and you have pretty significant weakness in your limb. Just like the brachial plexus, you can have problems in the lumbosacral plexus. Briefly, the investigative modalities, without a doubt, number one is the history and physical examination. You have to figure out, is there a sensory component? Is there a motor component? Is it proximal? Is it distal? Did it start suddenly? Did it start gradually? Do the symptoms fluctuate? Does it involve the eye muscles, etc.? We have at our disposal many other tests as well. The way you can't just order every test in every person, so the history and physical examination makes this a lot easier to do. Just give me another 5 minutes. EMG nerve conduction study. This is the major functional test of the peripheral nervous system. When you're doing an MRI, it's a structural test. You're seeing things, but you don't get to see the function. This is the literal opposite. You don't see the nerve, but you see how it's functioning. This is not the most comfortable test in the world. It's not something you want to do on your day off, but it provides pretty good information. It is certainly tolerable. On the nerve conduction part, you have a probe that depolarizes the underlying nerve. If it's a motor nerve, you'll see something actually move. If it's a sensory nerve, you're recording the measured response. You can see the probe that's recording right there. The EMG portion refers to a needle electrode examination where you use a needle and you put it in different muscles of the body. You check the muscles at rest and with activation. Most of the time, you're not even, believe it or not, looking at the muscles, but you're gathering information about the nerve going to the muscle. I would say on the order of like 20 to 1, I'm looking for nerve problems to muscle problems, even though the needle's in the muscle. So that's my last slide, but I had my staff take a couple videos so I could show you what that meant. So this is a motor nerve conduction to her median nerve. She's stimulating the nerve at a place in the antecubital fossa here, and she's measuring the movement down here. Remember, the median nerve does a lot of the thumb functions. This will be a stimulation of the left median motor response, first at the area just in front of the elbow, and then secondarily down by the wrist. So stimulate, you could see her move, and that's the waveform that was produced from it. Now you're not going to see it, she's going to stimulate again near the wrist, and the waveform will be bigger because it's closer to the recording electrode. And that's the bigger waveform. And then this is the EMG. So I'm checking her first dorsal interosseous muscle, which is a little muscle right there. Very easy to stick and usually not all that painful.
So now, doing the needle electrode examination by placing a needle in her left first dorsal interosseous muscle. Can you lift your pointer finger to the ceiling?
So I'm feeling for that muscle to stick out. That's why I asked her to do that. And if you listen, you hear a lot of popcorn noises.
Okay, gently lift it up to the ceiling.
And this is what it looks like on the screen when she's activating it. So the key is to make sense of that tangled mess on the screen there. And it's literally just pattern recognition. After a while, you just get used to seeing something in particular that you're looking for. But thank you for coming to hear me talk. I'm sorry we went a little bit over, but I'd be more than happy to answer questions.